Hello everyone. So we have a 16-year-old boy who comes to you for follow-up after having appendectomy 3 days ago. The patient was hospitalized for abdominal pain, vomiting, fever. Subsequent evaluation revealed early retrocecal appendicitis. Well, it was done in emergency without any perioperative complication and was discharged home the very next day. But the family noticed yellowing of the eyes, but he had no abdominal pain. Vitals are normal. On examination, there is mild icterus. Abdominal surgical lesions are healing well without any edema or redness. As far as the lab reports are concerned, you can see the HB normal, reticount normal, and even the TLC count is normal. Bilirubin is slightly raised, but direct is 0.4. That means primarily it is more of an indirect or unconjugated type of bilirubin. The enzymes are in the normal range. That means only abnormality is slight rise in the level of unconjugated bilirubin. Most likely diagnosis in this case. Answer is Gilbert syndrome. This patient most likely has Gilbert syndrome, but before I discuss the question, let's learn some basic concept about Gilbert syndrome. It's the most common inherited disorder of bilirubin metabolism. More common in boys. In our patient also, the patient is a 16-year-old boy. It's characterized by recurrent episode of mild jaundice. This is due to decreased activity of UTP, glucuronide transferase enzyme responsible for bilirubin uptake in the liver cell. Let me tell you the basic concept. This is the liver cell, and this is the blood vessel. And the blood, it has got unconjugated bilirubin attached to albumin, and they come to the liver cell. In the liver cell, unconjugated bilirubin is taken up. Albumin stays out. But for this entry, we need an enzyme, UTP, glucuronide transferase. If this enzyme is deficient, this uptake will not happen. So in that condition, there will be increased level of unconjugated bilirubin in the blood, and that is so-called Gilbert syndrome. So problem lies in the absorption of unconjugated bilirubin. These episodes may be perceived by stress like infection, fasting, vigorous exercise, surgery. Like in this case, the stress was of surgery. Appendectomy was done 3 days ago only. The patient has mild icterus following appendectomy, like in our case. How we diagnose? You can get unconjugated hyperbilirubinemia, normal CBC, everything normal, like in this case also. Everything was normal except slight increase in the level of unconjugated bilirubin. So the patient in our question, there is indirect unconjugated bilirubin is raised. Total level is 3.3, but mainly it is the unconjugated raised. The enzymes are all normal. There is no evidence of hemolysis. HB normal, even retic count is normal. There is no evidence of hemolysis. No specific treatment is needed. But the thing is, it's important to educate the patient about the benign nature of the condition and its inheritance pattern to prevent unnecessary diagnostic investigation. So nothing to be needed. Rather, you can say there's no specific treatment, or your treatment is avoid stress, that is hypoglycemia or other stresses. But patient education is very, very important in this case. What about other option? Acalculous cholecystitis is an inflammatory condition of the gallbladder. It occurs in critically hospitalized patient, and our patient was discharged on the very next day. So this is not the case. Lab reports are non-specific, but they may show leukocytosis. But in our case, the TLC count is normal. There may be mild elevation of alkaline phosphatase and enzyme, but in our case, everything is normal. What about option B, acute viral hepatitis? In this, anorexia, nausea, vomiting. Okay, but in our case, there is no nausea, no vomiting, no pain, enzyme level are extremely raised, very highly raised, more than 25 times of upper limit. But in our case, the enzymes are completely normal, especially aspartate and alanine aminotransferase, all are normal. This viral hepatitis is totally ruled out. What about option C, which is talk about anesthetic hepatotoxicity? This can halogenated inhaled anesthesia like halothane are associated with severe hepatotoxicity. It can be of two types of halothane hepatotoxicity: mild self-limiting characterized by mild elevation of aminotransferase level, and severe form that causes liver necrosis, fever, jaundice with grossly elevated enzyme level. But in our case, enzymes are normal, so it is very, very unlikely to be due to anesthesia. What about option E, iatrogenic biliary injury? It occurs most commonly following laparoscopic cholecystectomy, but very unlikely to happen in appendectomy. Well, when we talk about biliary injury, that lead to jaundice, fever, and epigastric pain. But in our case, yellowing of the eyes but has no abdominal pain or no nausea. So this option is very unlikely. Golden line to remember: Gilbert syndrome, the most common and inherited disorder of bilirubin metabolism, characterized by recurrent episode of mild jaundice. Usually this precipitated by some stress, maybe infection, fasting, vigorous exercise, or surgery. With the exception of elevated unconjugated bilirubin, liver function tests are all normal in Gilbert syndrome. Thank you very much.